Hello, everyone. Thank you so much for joining us for our third masterclass. And it is an incredible honor to have Professor Emerita Nanette Mutrie with us today. And it's such an important topic. I know clinically in my practice and in many others for family medicine, primary care, sport and exercise medicine, and so on, any allied health care providers that are joining us today. It's a topic that comes up a lot in terms of what can we do best for health and what is kind of the so-called best buy for health. And so we're really privileged to have Professor Mutrie here today with us to be able to explain some of the benefits of walking for health and really translating that evidence to clinical practice and to maximize our clinical impact in this area. So I just want to start off with a land acknowledgement. So I know we're all over the world that are coming in to be here for this webinar for this specific Western and Fowler Kennedy sponsored masterclass. We are situated, the Western University is situated on lands that I would like to acknowledge today. So it's sacred land upon which we're privileged to live and work, and we recognize the deep connection and longstanding relationship between Indigenous peoples in the land of Southwest Ontario and of London. We acknowledge the Anishinaabe, Haudenosaunee, Lenapehoik, and Chinanta nations whose traditional land we are gathered upon today, and we're deeply grateful to have the opportunity to be in this place. So a couple of housekeeping items. We've turned off the chat in general and we'll be using the Q&A today. So if you do have questions, please feel free to type them in the chat. In general, we've noticed that it's better that we save the questions until the end. And so to not disrupt the flow of the masterclass, but we will get to those questions and save some time at the end. Feel free to just drop them in the Q&A. You can also like other people's questions, so it essentially upvotes it and raises those questions to the top. The session is being recorded and the introduction will be followed. So my introduction now would be followed by about a 40-minute presentation with about 15 minutes of Q&A, but it can vary slightly. The masterclass was developed with input from our scientific planning committee, and thanks to Dr. Eric Wong and Dr. Sadia Jan, who are also on the committee that helped review the titles and so on. And really all of these classes came about because of input provided by family physicians who wanted to know more about specific topics in sport and exercise medicine, as well as musculoskeletal topics. So we hope that it's of value to your practice as well today. So finally, I have the immense pleasure of introducing our speaker today. So Nanette Mutrie retired as Chair of Physical Activity for Health at the University of Edinburgh in January 2022. Nanette has been directing the Physical Activity for Health Research Center since 2012. She's a chartered psychologist with the British Psychological Society and a fellow of the British Association of Sport and Exercise Sciences. She has extensive experience of conducting interventions aimed at increasing physical activity, and her research relates to helping people move more. So a particular interest for Nanette is how to communicate about physical activity to the public. And she is chair of the Active Scotland Development Group. And recently, Nanette has joined the board of Paths for All and strongly believes that walking is the best buy. And she's contributed to policy. So, for example, Let's Make Scotland More Active and the National Institute of Health and Clinical Excellence programs on physical activity and the environment and promotion of walking and cycling. And she's currently a member of the National Strategic Oversight Group for Physical Activity in Scotland. And Nanette received an MBE from the Queen in 2015 for services in physical activity for health in Scotland. Thank you so much, Prof. Mutrie, for joining us today. We are so honored and privileged to have you join us and share your insights and knowledge in this area. And so the microphone and camera is officially being passed over to you. Thank you.
Thank you so much, Jane, for that lovely introduction and also for inviting me to do this. It is my absolute honor to be able to speak across the pond and other parts of the world perhaps as well. I've got a strong affiliation with North America. I did my PhD at Penn State University, and more recently I had a lovely 1-month research visit with Guy, be speaking to you all, and I hope you find this topic interesting. As you've heard in Jane's introduction, it's a bit of a passion of my research to talk about walking. So Becky's helping me move the slides forward because we have a technical hitch with security. So I'm going onwards. Becky, please, to the next couple. This is your colleagues' disclosures, and going forwards, I'm trying my best to mitigate the biases that may exist, and in the question and answer you can tell me if I managed. I have no financial disclosures to make that are in conflict with anything you're doing. And then finally, on to the topic. So yeah, Professor Emerita is a lovely title. It means you do as much as you want of your other work that you used to love doing and get paid for, but now you don't get paid for it. So that's exactly what it means. But I'm still happy to be associated with the Physical Activity for Health Research Centre at the University of Edinburgh. And going on again, I tried to outline 4 learning objectives for today. I'm going to try and make you aware of the history of walking for health research from 1997 to some things quite current, to understand the role of walking in the context and individual change in behaviors, to know the evidence from one example of an individual level walking intervention. So I'm really thinking that is where you, as family physicians or practitioners and allied health professionals, will work. You work with individuals. And I'm going to show you a brief advice approach that we've created in Scotland for this purpose, and I hope you can evaluate for yourselves the pros and cons of that approach. So 4 things to go forwards with. Thanks again. Now, these milestones that you can see in front of you come from the International Society of Physical Activity for Health, and there are 3 slides that follow all the timeline of this. And of course, to the left-hand side is the very famous Jerry Morris 1953 paper, in which he looked at the differences in coronary heart disease symptoms and mortality for bus drivers and bus conductors. And of course, you can see the London bus there in the little icon. The bus conductors went up and down the stairs and walked along the bus to collect fares versus the drivers who were sedentary. I'm sure you all know that the evidence supported the idea that sitting down all day at your work was not good, but moving about the bus, collecting the fares and going up and down reduced your risk of coronary heart disease. So Jerry Morris really did the first walking study, as well as setting off the whole area of physical activity for health with that publication. But some time passes before we get any titles with walking in them. But curiously, well, not perhaps so difficult to understand, it was still Jerry Morris doing this in 1997 with his colleague Adrian Hardman. They wrote a paper about walking to health. And in that paper, they said that walking is the nearest activity to perfect exercise. And here is the exact reference for you to follow up. So Jerry Morris really has been an outstanding leader in the field, both promoting physical activity itself, but promoting walking. And in that article on page 328, they do declare that walking is the nearest activity to perfect exercise. So when we think about that, of course, it's legs, of course, it's arms, but a lot of people forget it's also core. If you're holding your weight correctly above your feet as you're walking, you're involving all the core muscles as well. And this is what I think he meant. We're designed to walk. All of our muscles get involved in that process. Thank you, Becky. And this, of course, became a watershed moment. This little slide comes from a paper or a chapter in a book myself and my colleagues wrote a few years ago, looking at the published studies with walk in the title from 75 onwards. And in there, you can see the 1997 publication that we've just mentioned, and it seemed to create an exponential increase in the number of people interested in walking. I think that was because, my own take on it is, up until that point, our world was fairly dominated by the notion that you had to be fit. And so walking was kind of excluded. We had the idea that at that point in time, the recommendations were probably do 3 times 20 minutes of vigorous activity a week. And so people couldn't quite get into their head that walking would be sufficient activity up until that seminal paper was published. Thank you, Becky. Now, in the International Society of Physical Activity milestones, nothing much happened between 2003 and 2011 on the topic of walking. There are many other things you might want to go back and look at there. For me, what's important is Michi's 2009 paper about effective techniques in interventions. Thank you for pointing at that. And we might come back to some of that later. You know, this is the behavior change at the individual level. And on again to the next timeline. And here we see up until actually 2022, I've added that to their timeline, 2 very important issues. So the first is in 2018, the British Journal of Sports Medicine had a special issue on walking. And actually it was a celebration of 21-year anniversary since the Morrison-Hardman paper. And we'll look in detail at some of that in a minute. And then in 2022, the World Health Organization publishes how to promote walking and cycling. So 2 new very important items into the timeline for you to follow up. So let's go to the next one. Now, in that special issue from the British Journal of Sports Medicine, the editors of the issue took a bold step. They entitled their editorial, as you can see on your screen, what Hippocrates called man's best medicine. Well, we kind of know that. It was an ancient idea. I'm sure that's what Jerry Morris was talking about. But they go beyond that. Walking is humanity's path to a better world. Like, whoa, that takes you into a whole other sphere of thinking. If we go forwards, what they were really referring to is somewhat encapsulated by the Bangkok Declaration, coming again from the International Society of Physical Activity for Health, on how physical activity is actually a force for global health and sustainable development. If we go on to the next one. At that point of the 17 sustainable development goals at that point declared by the United Nations, the International Society of Physical Activity for Health said, well, there are all these ones that are pulled out of the pie that physical activity can really contribute to. Of course, the central one being good health and well-being right in the middle, but other things that we're now very motivated by, particularly our younger generations. Climate action, number 13, sustainable cities and communities, reducing inequalities. So the editors of the special edition were saying, well, health is one thing, and we're really focused on it, but actually a lot more than that can be achieved through the promotion of physical activity, and I would argue the promotion of walking. And on to the next one. So if we just keep clicking there, Becky, this is the special edition itself. It has all of these articles and these very nice infographics that go with it. We've got cardiovascular disease, we've got promoting walking as a social behavior, reducing the risk of cardiovascular disease, a discussion about pace, which I'm not going to go into today, but you might want to ask me in the question and answer. Residential relocation, if you move to a better area, do you walk more? Walking for mental health and promoting walking at population level. And on we go. So walking for mental health is a particular area of interest for me, and I'm a co-author of this paper in that special edition. And the infographic shows what we discovered through a review process, that because it was the 21-year anniversary of that original paper, we found that when they wrote the paper in 1997, there was almost nothing to say about walking and mental health. But now there's a burgeoning field of research there. It's really grown. strong evidence that walking can prevent and treat depression and anxiety, and I'm a firm in that, but the strongest evidence is definitely preventative. But more positive things as well. Walking may improve positive mental health outcomes, such as feeling happier and self-esteem. And then we've got this double bonus that if you walk outdoors in a natural environment, then we may get additional mental health benefits. So that's a particularly important achievement over the 21 years that we now have this area built into the evidence base. And moving on again. And then finally, this is the 2022 walking and cycling evidence to support policymaking and practice from the World Health Organization. And the next one. So they have some very nice infographics. They have health benefits of walking and cycling. You can see on the left all the things that they have strongly evidenced. The World Health Organization are not going to write in things that are not strongly evidenced into their papers. You can see what they all are, all the things that perhaps you are dealing with on a daily basis with your patients and clients. And then things that it improves as well, you know, at the top of that list: cognitive function, mental health, sleep quality, weight, muscular and cardiovascular fitness, and bones and functional health. So lots of benefits. And moving again. And then they too go a little bit beyond health, and they show the benefits to walking and cycling for the environment, for health, and for mobility, you know, getting around places in your community, in your city where you live. And again. So that's great. You know, World Health Organization actually declaring that walking and cycling are important items to be considered for health and beyond health, but they're very different modes to promote. Indeed, on being asked to critique their papers before they go out, I keep trying to say, don't put walking and cycling in the same place, because they're very different things to promote. Now, I declare that I own 3 bikes and I love my cycling, but I know it is not the solution in the way that walking is. Cycling is indeed a minority activity in most places, unless maybe you live in the Netherlands, in which 50% of the population cycle. Everywhere else, it's a minority activity. Now, walking will reach a much higher percentage of your parents than cycling promotion ever will. And walking is more equal than cycling. There's a less of a gap between the numbers of women and men who walk compared to cycling. There's a wider age group involved in walking than in cycling. And socioeconomically, there's a smaller gap between the richest and the poorest in terms of walking in comparison to cycling. So therefore, this is why I often say walking is your best buy and here for clinical practice. And on to the next one. So now to learning objective 2, but the start of that is just what we've been doing. So this framework completed by Salas and Owen way back in 1999 is a very nice way of talking about how to build evidence for physical activity. And in this case, we're building it for walking. I think we've established the links between walking and health already in the presentation. So the next thing would be to look at measuring. Then we look at what the determinants are, and we'll come back to that as we get along. So measuring walking in step 2 here. Well, walking might be the easiest thing to measure. I mean, almost everyone in their phone or with a Fitbit or actually a little old-fashioned pedometer has a way of measuring walking. And you can't say that for all kinds of activities. It's so hard to measure strength in this kind of way, or to add together all the activities of the day. So step counts are really, really critical and can be easily measured. It can be used for personal gain, like a behavioral tool to set goals, to help yourself monitor. But, you know, there's a great big possibility that it will become epidemiological data if we can capture it and really have a good measure across the population of things. We can also see walking in self-report instruments. It is part of the IPAC, the International Physical Activity Questionnaire. And we've got pretty good agreement now that walking is a moderate activity. Using MET values, it's usually defined as 3 if you're going briskly, or 4 METs, or the other way around from that. 4 METs if you're going briskly. Thank you. So we got an easy way to measure walking, and now we look at determinants. So if we go to the next slide, this is, of course, a wildly busy slide, but it's important to put it all in one place. It's a little bit of a cheat. It's not exactly the determinants of walking. What it is the systems map of physical activity that we've just produced in Scotland. The bottom reference there would take you to the whole document. Now, what this brilliantly conceived diagram, I didn't conceive it, but I've helped with the work. Flora Jackson, my colleague in Public Health Scotland, did. It tries to encapsulate, you can see up at the top there, the 8 investments that work, the global plan for physical activity, evidence that comes from the National Institute of Clinical Health and Excellence, all sorts of evidence bases into that. And then it tries to look at all the things that influence physical activity. Now, if we tried to focus just on walking, if we looked at the orange ones, well, they're the kind of determinants which we would look at for general physical activity, which I've been declaring that I think are more beneficial towards walking than other activities, opposed against cycling, but less gaps between the rich and the poor, between the old and the young, between men and women. And walking captures these kinds of determinants, and they're less disturbing to us than they would be, for example, if you were looking at team sports. They'd be hugely influential. And then if we looked at the green things, this is all about infrastructure. So a particularly important one is, are there places to walk? And I think Canada does a little bit better than this than your southern neighbor there, because there are many streets that I've encountered in US cities in which you cannot walk along. There is no sidewalk. So sidewalks, places that are safe to walk, places that are well lit, infrastructure. And then finally, if you look at the purple, there's issues in there relating to walking as well. Walking culture. So if walking is an odd thing in your neighborhood or your country, this is something that has to be tackled. There are many, many determinants. If it's common to walk, then you don't feel odd doing it. And actually in Scotland, we've discovered that the pandemic created an improved walking culture. Many, many more people went out walking unabashed and are still doing it, whereas there were fewer people doing that before the pandemic. A possible tiny benefit from that world catastrophe. So this is complex, of course, and that's really the point to make. There's no easy thing to say, these are the determinants of walking. There are many, many things at influence here. And on to the next slide. So in the behavioral epidemiological framework, we try to establish determinants. We then look at how to intervene with some of these determinants in mind. So let's go on. At a population level, there was a very nice review in that special edition of the British Journal of Sports Medicine to identify ways to promote walking at a population level. And these 3 highlighted areas were what the systematic review told us about. So mass media as an approach to helping the population walk more. What we've just mentioned in the systems mapping or the determinants, environmental infrastructure, community events that promote walking, and environmental change approaches to create safe walking routes and paths. And one of the in Scotland are a lot of long distance paths. Now, that's extreme level walking in a sense, but people can do small segments of them in a safe way. You're out in the green hills, blue sea, river environment that possibly adds to the mental health benefits. However, moving on again, I'm trying to reassert here the role of reaching individuals. And amongst the world of physical activity for health researchers, individual approaches were given a kind of bad name because people said, well, they're not scalable. What we need are things that could reach the whole population. And of course, that's what this ecological model of factors that influence our health tries to say. And Jim Salas is very strong on creating this idea that using policy, community issues, organization, interpersonal are probably more important at achieving a population change than the individual level approaches. However, if I can just get Becky to click the next two, I'm keen on the individual approaches, particularly for yourselves who work mostly with individuals in practice. And if we can reach them with things that lots of people can do, we too are contributing to the population approach. So I'm not going to dismiss individual level approaches. I want to seriously hang on to them. And on again. So here I'm going to give you an example of an individual level intervention, which has proven itself to be scalable in a sense, and which gives the essence of the things that you might do in your practice. So on we go again. Well, this was a great, I think I would put this into my history of projects as the best one I've ever been involved with. So these are football, soccer in your world. The fans of the main clubs around Scotland were reached via their clubs and via their coaches. On we go. And the title of the project, Can the Draw of a Professional Football Club Help Scottish Men Lose Weight and Become More Active? And I think we've extended this work, as I recall now, into ice hockey in Canada. I'm pretty sure of that. And we're moving on again. So these are the kind of scenes from the football fans and training process. Men who were overweight were reached via their clubs. They were the fans of the club to attend a 12-week in-club educational process with activity involved. Of course, I was the lead for activity, but the essence of it was to help men lead a healthier lifestyle, but it was actually a weight loss project as well. So there was nutritional elements built in. So on we go again. The full trial here, the flow diagram is just to point out the numbers involved. So 374 in the intervention group, the comparison group, the same, of course. That comparison group had to wait 12 whole months before they were allowed to join the program. And that was tough because they really wanted to join in. There were 12-week measures, there were 12-month measures with pretty high retention rates, as you can see there at the bottom, 94% for the comparison group who were champing at the bit to be allowed to receive the football fans and training intervention, and 86% for the people who went through the intervention first time. Now, it seems odd to be just men. Our analysis was, there's a real problem for inactivity with Scottish men, and there's a real problem for obesity with Scottish men. And so whilst we're always looking for equality, and now football fans does reach the women fans of clubs as well, for this purpose, it was men we chose. And on we go. So these are the components of the 12-week program. They learned about food, they learned about alcohol awareness, they were taught some long-term behavior change strategies. Weight loss was the concern, and increased physical activity was the concern. And one more click takes us to an important part. Each session was run as a group session with one of the club coaches, sometimes, you know, the first team coach, who would be famous to the men who were fans. They loved that, and it created a set of banter which sometimes would not be repeatable to anyone else about how they exchanged this educational program. But that was a key ingredient to the success of this program. And on we go. So this was the main physical activity component, which was actually homework. I mean, I think everyone realizes that whatever you're doing on one day of the week isn't going to help that much. So we created a personalized pedometer-based daily walking program for the men. They actually got a pedometer as an addition, because not everyone at that point had phones. And quite often, you know, I prefer the pedometer myself because I often don't carry my phone with me. But it's much more common that people can record this easily on their phones. So on we go again. I think you just need to click all the way through them, Becky. This pedometer program was based on a previous piece of research in which we had very successful behavior change using this step-by-step approach. Every 2 weeks, we adjusted people's goals. Rather than setting everyone the same goal, we took baseline measures of their step counts, and we added an additional 1,500 steps on at least 3 days a week. That was their goal. As you will recognize, that's about 15 minutes. Then the next 2 weeks, they had to increase the frequency towards 5 days of the week. Then in weeks 5 and 6, we were adding another 1,500 steps, so 3,000 steps over their baseline level, which you will recognize as 30 minutes. That increased to 5 days in the week, and then their goal was to maintain it. So there was no requirement for that to be done all in one burst, you know, following every nation's and the World Health Organization guidelines. These steps can be accumulated. They don't need to be done in 15-minute or 30-minute chunks. And on we go. This is the result of the fundamental research in which we've got the intervention group receiving that little pedometer program in blue versus the control group of that research in red. And at 12 weeks, we had successful, significant change. If you just pop on that next bit of the slide, increasing over 3,000 steps a day by week 12, which was exactly the goal. And on we go again. So this was built into the football fans in training, along with these weekly sessions in the stadia, where the coach helped the men understand all the components of health-related fitness. And on we go. So the main paper was written in The Lancet. Of course, we were exceptionally proud of that. There's been so few physical activity research papers in The Lancet, and we're really thought we had something very good going on here, because at 12 months, the men did lose around about 5% of body weight. Any of you in the obesity research world will know how difficult that is to achieve. And in terms of physical activity, they increased by around 3 hours a week. So obviously the research tools for measuring this were accelerometry, versus the pedometer was a behavior change tool. So that was carefully measured, you know, by the researchers at baseline and 12 months. There was also decreased sitting time, at least in the 12-week period. And on we go. Now, I wanted to just focus on the walking, because in fact, when we submitted the proposal to the grant awarding agency, we had this one unfortunate comment that came back saying there's a major flaw, and it seemed to have my initials beside it, that comment, men will not walk. So very quickly we got on to working out what was going on here and explored the value of the pedometer in walking. And this was led by my colleague Kate Hunt, and the paper references at the foot there. So the pedometer-based part of the football fans in training was really well accepted, and it was seen as a valued technology for motivation, for self-monitoring and goal setting. So it became routinized in men's daily lives because they were walking. If we go on again. And if you just click on the first one. So if you've got any Scottish heritage, you will love just repeating some of these words here. This guy going, I never go out without my pedometer. It's amazing. I wear it every day. It's tangible. I think everybody was highly delighted with the pedometers. And again, on the next one. This one I always love. It's given me a good kick up the backside when I've had my shower. First thing I do is put on, it's made me consciously go out of my way to walk more. And again, really good, an amazing wee device. Before you maybe have thought you'd been staying active, but when you look at your pedometer, you realize you hadn't. So they really valued this piece of technology and how it helped them. And on we go. And I think you can just click through the next bit. We also showed it was very cost effective, that to use this process to achieve the recommended levels of physical activity was under £100 per person. And on we go again. So final part then is translation into practice, what we've been wanting to get to really through this whole process, but this is the behavioral epidemiologicals framework. We can't really get good practice happening until we know all these previous steps and we learn back and forwards from them. So let's go forwards into translation into practice. And two ways of looking at this. The first to community settings, which you may be able to advocate for, but the second to clinical practice, which you will be able to do. And again. So here in Scotland, this is what's happened with our translation of the evidence into community settings. We have a strategy, a walking strategy. In the left, we have an action plan of how that strategy is being doing. As you can see, it goes to 2026. We're currently reviewing it. And we also have an active travel plan, because walking is an important ingredient of that. Although I would say, again, it often gets overlooked in that sphere in comparison to cycling. And again, Becky, thank you. I'm currently a director of this at arm's length government agency, Paths for All, and they seek originally to create safe walking places, but now they promote health walks. So people can find a health walk near them. So that's a community translation of the evidence. And on again, this Pass for All system uses a pedometer pack, so people can get a pedometer, follow the plan of the short-term goal setting, step by step by step, literally small amounts at a time, to eventually accumulate towards the recommended levels of activity. And again. And Pass for All do a number of things. For example, a walk at work challenge and award. And on we go again. Now, so much for the community setting. You could indeed be advocating for that. You could be thinking of ways to help you and your colleagues walk more at lunchtime, walk to work, leave the car further away, all sorts of things like that. But what do you do with a person in front of you when you've got hardly any time? So this process comes from Public Health Scotland's approach. I helped to derive it and write it. So it should take less than 3 minutes, this kind of script. You can see at the top is raising the issue. How physically active do you think you are? One of the best things we can do is to stay healthy, to stay healthy is to be active. And of course, we can put walking right into it. The next step down is a screen, and it's the Scottish Physical Activity Questionnaire, but that won't apply to you. There will be another way to do it. Indeed, I often think you could just ask people to show their walking steps on their phone if that's something they do. Take photographs of it and send it to you. It could be a screening method. I'm not sure. Then your job is to provide some feedback, and you're going to say you might not be as active as you could be, and we'll take that conversation forward if you want. Or you might be saying, that's great, you seem to be doing well with the recommendations, well done, keep it up, and a positive feedback there. And so that goes to a positive exit strategy for those who are active. And then on the left-hand side, it's an exit strategy if people are not yet ready to change. So you've raised the issue, but they're not interested in changing. You get a no from that. Are you interested in being more active? You get a no, and that's an exit strategy with maybe some resource to give them. A website, a leaflet, a possibility. And then if they are interested, you can do a little bit more brief advice, and you can see what it suggests at the bottom, some benefits and some information. And of course, here I would be saying the main thing we should do is promote walking to these people. On we go again. So what are the barriers to practice change? I think you will know them better than me, but these three came to me quite easily from reviewing other work in this area. Of course, time is a barrier, but there's an example of a 3-minute brief advice approach. But you could also consider additional resources, leaflets, websites, use of practice nurses or specialists. I mean, I'd love to see a physical activity clinic, just as we see a wellness clinic or a diabetes clinic attached to family practice. Then I would think knowledge of behavior change might come into it, but you know, the pedometer approach, that idea of asking someone to count their steps, certainly has motivation built into it. People like the technology, as we've learned. People like the goal setting. People like be able to self-monitor, and that could indeed be written as a walking prescription, that set of goals that I showed you earlier in describing football fans and training. And record keeping's one. You know, if you're constantly having to ask your patients, how active are you? It'd be nice, as you would say to them, now I'm just looking at your blood pressure record here for the past 5 years. Wouldn't it be nice to look at activity patterns that way? And we might be close to that with all of this built-in technology that phones have. And of course, exercise as medicine is an approach you may well know of, and they consider this a vital sign. So in your practice, can you find a way of record keeping? But I'm sure you'll have more to offer me in the question and answer about that. And on to the end, I think, Becky, now. So these were my takeaways from or a summary really of what I've been trying to say to you in this last 40 minutes. Yeah, we have strong evidence now of the health benefits of walking, and wider benefits include active travel, climate change, sustainable cities. That must not be dismissed. I think some people have motivation much more towards being sustainable, avoiding using their car, than they might have towards health. So these motivations have to be taken into account. Walking is easy to measure for most people. They carry it in their phone or on a Fitbit or something. And what we need to recognize is that there are multiple determinants of walking, ranging from individual issues to environmental issues, to advocacy lacking, to walking culture lacking. So the individual level promotion, I think, needs to involve some goal setting and some step counts, and they could be easily added to that brief advice script that we worked through. Or you could write it out as a prescription, and we know that patients really value the advice of their doctors. So that prescription is probably a very, very important tool. And to finish up, I would just reiterate what I tried to argue for in the beginning, that walking is the easiest mode of activity to promote to your patients, and therefore it is your best buy. Thank you for listening.
Wonderful. Thank you so much, Nanette. That was wonderful and full of good takeaways for primary care. Absolutely. So thank you for that. And I love this very easy message at the end in terms of actionable items that we can do for our patients. We can now certainly ask some questions. So I might just start with that. I know I have a couple of questions, and I'm sure the audience will as well. We're going to prioritize them at first. And so the first question that I have is from Kyle Winnick. Hi from South Africa. One big challenge we have in our communities is safety and infrastructure, pavements, or safe walking paths. What would you recommend in these patients? So he has two, so maybe we'll start with that one. And thank you, Kyle.
Is Kyle going to ask it, or should I just?
No, I'm reading it from his, I'm reading it from the Q&A.
Well,
yeah. So the question really about safety and infrastructure or safe walking paths.
Yeah, so that's a huge question that, you know, we can't answer immediately, because it requires advocacy from local community groups to their councils or local authorities to help improve on that. So that's a strong advocacy role. And in the meantime, my best advice is to form little groups that can walk together for safety. So health walks might be something that a practice could initiate and help people meet together and therefore feel safer as they walk. Good shoes or footwear to help with poor underground conditions might be another item there. But of course, the longer term thing is to promote the safer environment through the people who are responsible for creating it.
Absolutely. Thank you. And the second question was in relation to patients with lower limb osteoarthritis and elderly patients. How would we motivate these patients to mobilize and get healthier?
Well, I'm sure you're more expert on this than me, but of course, moving is a key to preventing the pain in osteoarthritis. And walking is, providing it's pain-free, you know, short amounts of walking should be okay. I would say emphasize the accumulate message. Mm-hmm. So it could be 5 minutes, 3 times a day, and see how your osteoarthritis responds to that. If it responds badly, then, you know, lower the thing to 2 lots of 5 minutes, and then build it up. So the accumulate message gives us lots of opportunities to try and help people move a bit more without it being very demanding impact on knees and ankles and hips.
Yeah, absolutely. No, that's a great point. And I know with the patients that we've seen as well, in terms of a lot of them come with the message that they think it's more of a wear and tear issue, and that any more loading will be detrimental. And it is quite a bit of normalizing, reassuring, and facilitating that aspect of movement. Kind of motion is lotion, so to speak, right? Yeah.
The other thing is the walking poles, you know, not exactly you know, the brisk walking to make higher oxygen consumption. I mean walking poles that steady your gait and give you a little more balance, and so less impact. I think that is another additional help for people that are finding pain in their lower limbs.
Excellent point. We have another question from Robin Love to ask, can you comment on speed? So I have many patients count walking their dogs as they're walking, but if their dog is anything like mine, we do a lot of stopping to sniff. And what would you tell them about how fast they have to go to make the walk beneficial? Thank you, Robin.
Yeah, this is a great question, and one that I have a constant debate with my physiology colleagues. As you heard Jane introduce, I am a psychologist. My physiology colleagues, if I can start with them, are a little obsessed with disease control And so pace is important to them. As a psychologist, I'm obsessed with adherence to activity as long as you can. And
Right.
so the pace you should walk at is the one that makes you feel comfortable. And brisk walking, I think, should be banned from the lexicon altogether, because it means a different thing to everyone. Brisk walking makes me think I'm going slowly, but I'm going at this pace that is good for me. So the main message I would give is walk at the pace you feel comfortable. And if you have to stop and start with your dog, you're getting a lot of steps in, you are outside, you're enjoying the weather, whether it's good or bad. And that is as important as pace in my book, because you will keep doing it. And you'll keep doing it because your dog needs to do it. I'm a big fan of dog walking as a promotion of walking itself. So I think I would disengage the topic of, am I walking fast enough for benefit? You will definitely be getting benefits. And as long as you're enjoying it, you will keep doing it, is my message.
Wonderful. I think a lot of patients and providers are happy to hear that message. You stop to smell the roses or whatever the case may be, and still get your daily walk and the benefits and things like that. It's wonderful. So a third question from Sherry Baskerville. It cuts off your last name. Sorry, Sherry. How widespread is promoting walking in shopping malls throughout the world?
Throughout the world, I'm not sure I can answer that. I definitely know from my North American experience that is used a lot. It is not used much in Scotland because I would say we don't have enough shopping malls. We haven't got that promotion. But of course, it's a good thing when the weather is bad. And so finding alternatives, I tell people in Scotland when the weather's bad to go and walk around our biggest DIY store. That's much bigger than any store we've got. So up and down the corridors of that are similar. So I think it's a great idea, but how well is it used throughout the world just depends on the culture of building such malls. And that is not widespread, I don't think.
Fantastic. Yep. It's a good question. I certainly don't know either. It'd be interesting to find out. And Jeff Knowles is asking another question. Would you please comment on using heart rate as a guide for intensity? So some people have quite a quick heart rate response with little effort, considering the medical background, while others will require more if they are healthier.
Yeah, again, it's a kind of physiologist versus psychologist argument, this. I'm not a fan of using heart rate for some of the reasons you've mentioned there. People in beta blockade, for example, will not really be able to do this that well and find themselves really stressed to try and reach their heart rate. So I'm not a fan of that. I'm not even much of a fan of the effort scale anymore, the sort of Borg scale of effort, which is well used. It's just about, you should get yourself to a somewhat hard level of activity, moderate levels of activity, and you're gauging that versus a really easy level where you're sitting down or walking around the house, to the extraordinarily high level of maximal effort, walking as fast as you can for as long as you can. So usually on the scale of 0 to 20, it's around about 12 to 14. I quite like that. But what I like a lot more is the 7-point feel-good scale, which Paddy Ekakakis has used. Now, if you don't know that, look up his website. And this is simply going, I feel good doing this, going up the way or going down the way. And you must be in the positive scale for me to enjoy your walking and to come back and do it more. Some people want to hang on to an ancient athletic training idea of no pain, no gain. That should also be banned from the lexicon, I believe. There's no gain with pain, in my view. So we need to use the feel good scale instead of heart rate or effort. Just walk at a pace that makes you feel good. And I think all the benefits will come.
Wonderful. Thank you. There was a follow-up comment. Thank you for those comments and insights. I appreciate the various points of view. I agree wholeheartedly about needing to lose the no pain, no gain. So another vote of confidence there. Thank you, Jeff. What about those? Because I know I've had this question as well as an advocate for walking. What about those who are unable to walk for transportation or activity? What kind of advice would you give or insight do you have on that?
Yes, so this is tricky. What we do say, most people can walk, but of course some people can't, and some people can't even use a wheelchair. So we've got people with disabilities that are maybe using walking aids, and so they should also be encouraged to walk, use their walking aid, take it out with them round the block. Again, the idea of accumulate in small amounts really helps us with advocating walking for people that have to use a walking aid. And people that are in wheelchairs, of course, they have received this message: walk more, sit less. Now that is awkward. We haven't done that well. We have not done that well. We've only recently understood that that is not helpful to the grouping who are in a wheelchair. So in our Scottish policy, we now talk about walking and wheeling. And so the people in wheelchairs are using their arms and upper bodies, and that will be their benefit of the exercise. But being out and being in green space is also an additional benefit for them. So there's many benefits for them to increase their wheeling, and that's the parallel from walking to wheeling, and using both of these words in promotion is how we are trying to address previous errors I think we've made in this area.
Wonderful. Thank you. So we have one more question from the audience. If there's any further, maybe we can do follow-up. I know we could go into depth for hours on this topic. It's fantastic. Sherry's just asking, have there been any studies with regards to health benefits of water walking? So for those that have chest deep lanes in their local pools.
There has been research into that. None of it in Scotland. You would probably freeze to death trying such a thing, even in a swimming pool, because they're not brilliantly heated up. But certainly Australia has produced some evidence that that is a very good method of walking. Again, that would be very relevant for people with osteoarthritis or difficulty in walking, and obviously also in hot climates where it is difficult to sustain walking in the heat of the day. So yes, I've seen that evidence, and wherever that's available to people, and of course it's not available in too many parts of the world, the idea of being able to walk on a lane of water, I think it is a substantial addition to how we can promote walking.
Wonderful and lovely suggestion. Thank you, Sherry. And one, I think this is just a comment from Kyle. Thank you for this talk and a series of talks, so important, especially in third world countries or non-developed countries, developing countries, to promote something as simple as walking and where money is not accessible for a gym. And absolutely, I do think that does come about in terms of access to facilities, that just the simplicity of walking, the ease of walking certainly does lend itself to promoting health benefits. It's great. Well, it's 12:58, at least here in Ontario. I know it's other hours of the day where our attendees are. Thank you so much to our audience for joining us and for your engagement, for your excellent questions. Nanette, you've certainly convinced me that walking is a best buy for health. I love your takeaways, certainly for the environment, from a practical perspective, for the general public, for patients, for healthcare providers providing advice. It does really seem to be something that promotes health, and that is something that can be taken up easily, and especially outside with different modalities can certainly be helpful for us. So I really did want to thank you for that. If there's any last resource or comment that you would like to make in terms of if people wanted more information on prescribing or even just advising people about walking for health, is there any place that you might want to direct them to?
I suppose I should direct them to the Paths for All website, which is on one of the previous slides. It's our nation's organization, a charity, of course, to promote walking, and all the things that they've built into their programs now could indeed be copied elsewhere, including walks in which everyone stops and does a little bit of strength exercise as they go around the route, because that's one of the issues of walking. Might be the best thing to promote, but it misses out gaining strength in the way that we might need, especially as people get older. So yeah, that particular place might give you a few more resources and ideas.
Wonderful. Thank you so much for sharing your wisdom and insight and wealth of knowledge and experience in this field. We're very fortunate and grateful for that. Thanks to everyone who's attended today's webinar, and of course, those that are listening on the recording later on, and all the best, and have a great day. Thank you.
Thank you. It's been my absolute pleasure to be involved.